Jazakallah. I would like to introduce Mr. Professor Faruqi. हालांकि ये किसी तारुफ के मुहताज नहीं है, माशाल्लाह, renowned personality of Pakistan. आप प्लीज प्रोफेसर जवेद इकबाल फरूकी जो हेड ऑफ डिपार्टमेंट रहे हैं लेडी रीडिंग हॉस्पिटल में, जो खैबर मेडिकल यूनिवर्सिटी है, पास्ट प्रेसिडेंट पाकिस्तान सोसाइटी ऑफ हेपेटोलॉजी, और करंटली प्रैक्टिस कर रहे हैं एज अ हेपेटोलॉजिस्ट एंड गैस्ट्रोएंटरोलॉजिस्ट अल हयात क्लिनिक एंड रिसर्च सेंटर. वेलकम प्रोफेसर फारूकी, प्लीज आप अपनी प्रेजेंटेशन स्टार्ट कीजिएगा सर.
थैंक यू वेरी मच. Can you see my slides?
Yes, sir.
Thank you very much. Once again, thank you very much, Sarmi Pharmaceutical, for giving this opportunity to share our thoughts on the World Hepatitis Day. And before starting that, very sorry from the audience for the delay. You know, जब चीजें आपके हाथ के कंट्रोल में नहीं होती हैं तो ये होता है. There were some net issues, so I hope कि इंशाल्लाह the ahead अच्छा रहेगा. Well, the topic assigned to me is the strategies for hepatitis elimination and its challenges. We all know कि आज World Hepatitis Day मनाया जा रहा है, और World Hepatitis Day is one of the WHO's 7 officially mandated global public health days. पूरे साल में WHO 7 different days मनाती है, health days मनाती है. World Hepatitis Day उसमें से एक है. और ये क्यों 28 जुलाई को मनाया जाता है? The reason is that this is the birthday of the Dr. Bloomberg. Dr. Bloomberg discovered the hepatitis B virus in 1967, and 2 years later, he developed the first hepatitis B vaccine. और इन्हीं की वजह से इनको फिर नोबेल प्राइज भी दिया गया. टारगेट ऑडियंस मेरी इस टॉक की is the doctors from primary care physicians to the consultants. अगर कोई नर्सिंग पैरामेडिकल स्टाफ हम सुन रहे हैं, उनके लिए भी कुछ मवाद है. आई होप कि कुछ गवर्नमेंट ऑफिशियल्स इसको सुन रहे हो, इनको देख रहे हो, क्योंकि एट द एंड हम देखेंगे कि जब तक गवर्नमेंट और सोसाइटी की ओपिनियन होल्डर्स और जनरल पब्लिक एक लाइन पे ना हो, उस वक्त तक हेपेटाइटिस एलिमिनेशन एक ख्वाब ही रहेगा. ये मुश्किल है कि एक बंदा अपने तौर पे कर सके. हमारा रोल यही है कि हम गाइड करेंगे कि हेपेटाइटिस एलिमिनेशन की स्ट्रेटजीज क्या है, कैसी उनको इम्प्लीमेंट किया जाता है और कैसे इनको आगे लेके जाया जाता है. We all know that hepatitis is one of the major health problem worldwide. चाहे अमीर है, गरीब है, हर country में this is one of the issue. And we all know there are 5 types of hepatitis viruses: hepatitis A, B, C, D, and E. And this is the hepatitis A, B और E mostly जो कि acute liver failure करते हैं, इसलिए इनकी importance होती है. Acute liver failure में when the liver fails, the patient becomes jaundiced and liver becomes swollen, and कुछ fraction of patients में even they lose their lives. तो इसकी ये importance है. लेकिन ये जो आज का दिन मनाया जा रहा है, mostly this is because of the hepatitis B and C, which are the 2 leading causes of chronic liver disease of viral etiology. And what they do कि जब ये acute hepatitis करते हैं और अगर acute hepatitis fully treat ना हो जाए, it changes into chronic hepatitis. Chronic hepatitis जिसे दायमी सोजिश जिगर बोलते हैं. And if it is not treated in time, so what happens, the liver starts shrinking और इसको बोलते हैं cirrhosis liver. जब वो liver अपनी functional loss करना मुकम्मल तौर पे या मुस्तकिल तौर पे loss करना शुरू करता है, and another complication happens, that is the liver cancer. And because of this sequelae and the stages of the chronic liver disease, WHO is holding this World Hepatitis Day on every 28th July of the year. ये जो मैंने बोला कि जो chronic hepatitis और जो cirrhosis बनते हैं उनमें we know the complications are, most of the complications are the hepatic encephalopathy when the patient's sensorium is faulty, उसको थोड़ा सा मदहोशी आती है, बात भूल जाता है, confuse होता है, even it can become comatose, पेट में पानी का बन जाना, ascites, kidneys का fail हो जाना, hepatorenal syndrome because of the cirrhosis. लेकिन सबसे जो dreadful complications है खून की उल्टी आना, hematemesis and melena, और जो मैंने बोला कि liver cancer. So because of these very known complications of liver cirrhosis and chronic liver disease, WHO ने ये प्रोग्राम दिया 2015 में, एक टारगेट दे दुनिया को कि नेक्स्ट 15 years में, that means कि 2030 में तक वर्ल्ड से हेपेटाइटिस को हमने एलिमिनेट करना है. Why the reason was, this is the when the WHO analyzed the mortality from 2000 to 2015, जब 15 साल की mortality उन्होंने देखी, what happened, ये रेट जो है, this is mortality or death associated with HIV. HIV से जो अमवात हो रही थी वो आहिस्ता आहिस्ता 2015 तक नीचे जा रही थी. Tuberculosis से पूरी दुनिया में जो अमवात हो रही थी, they were going down. Okay. Similarly, were the deaths because of the malaria, they were also on the downhill. But in comparison to these three, HIV, tuberculosis, and malaria, the mortality or deaths associated with chronic liver disease were on rise. ये आहिस्ता आहिस्ता बढ़ रही थी. तो एक और, अगरचे हम टीबी, HIV, मलेरिया पे तो कंट्रोल पा रहे थे, उनकी मोर्टेलिटी को तो कम कर रहे थे, लेकिन जो कि क्रोनिक लिवर डिजीज, हेपेटाइटिस बी, हेपेटाइटिस सी से जो मोर्टेलिटी थी, जो डेथ्स थी, वो अनराइज थी. दैट्स द रीजन इन 2015 UNO, United Nations, included hepatitis in its sustainable development goals. ये उसने रखा कि अब हमने हेपेटाइटिस पे कुछ काम करना है. And the next year in 2016, World Health Assembly adopted the Global Health Sector Strategy on viral hepatitis with the aim to eliminate hepatitis by 2030, जो कि 10 साल रह गए हैं. ये स्ट्रेटेजी क्या थी? स्ट्रेटेजी definition थी कि we should eliminate viral hepatitis as a major public health threat by 2030. और हम कैसे करेंगे? अगर हम 2015 से 2030 तक, अभी 10 साल हमारे लिए रह गए हैं, 5 साल गुजर गए हैं, अगर जो 2015 में total deaths because of hepatitis B and C combined, they were around 8 million. तो ये टारगेट रखा गया कि ये 2030 तक 0.9 मिलियन तक हम नीचे लेके जाएंगे पर ईयर, और ये हो जाएगा 90% रिडक्शन. दिस वाज दी इंसिडेंट्स हैपनिंग न्यू इन्फेक्शंस, जो कि हर साल 80 लाख नए मरीज उस पूल में जमा होने थे, ये जाएंगे तकरीबन 9 लाख तक. सो 90% रिडक्शन इन दी न्यू इन्फेक्शंस. एंड अब तक 2015 में अमवात वर्दी 1.4 मिलियन, 14 लाख. इट हैज टू बी रिड्यूस्ड बाय लेस देन 0.5 मिलियन या 5 लाख तक. दैट वाज 65%. तो टारगेट ये रखा गया कि 2030 तक नए केसेस बजाय 80 लाख के अगर 9 लाख हों, और इनकी वजह से डेथ्स अगर 14 लाख की बजाय 5 लाख हों, तो ये हमारे टारगेट्स को अचीव कर लेंगे. और कब करेंगे? अगर हम 90% ऑफ द पीपल इन्फेक्टेड आर डायग्नोज्ड. यू नो, आज 2015 में और उसके बाद भी जितने दुनिया में मरीज हैं हेपेटाइटिस बी और सी के, इंक्लूडिंग पाकिस्तान, इसमें कोई 80 to 90% को पता ही नहीं है कि हमें हेपेटाइटिस बी ऐसी है. तो एक तो ये था कि उस पूल में जितने भी हैं, हर साल जितने भी टोटल केसेस होते हैं, उसका 90% टेस्ट करके डायग्नोज हो जाए. पहली बात ये थी. दूसरी बात ये थी कि इन डायग्नोज केसेस में से 80% को ट्रीट किया जाए. ठीक है. एक और चीज थी कि जो हेपेटाइटिस बी की वैक्सीन है, क्योंकि ये ऑलमोस्ट 100% प्रिवेंशन देती है, आपको बचाती है, तो 90% लोगों को ये, एडल्ट्स एंड चिल्ड्रन को ये मिल जाए। और अगर 100% ब्लड जो ब्लड प्रोडक्ट्स ट्रांसफ्यूजन होती हैं, अगर वो सेफ हो, BC स्क्रीन्ड हो और उससे साफ हो, और 90% इंजेक्शंस जो कि यूज होती हैं हेल्थ केयर सर्विसेज में या कोई ड्रग यूजर्स यूज करते हैं, वो अगर साफ होंगी, तो जब ये टारगेट्स हम ले लेंगे तो हमारी न्यू केसेस की इंसिडेंस 90% पे रिड्यूस हो जाएगी और ऑटोमेटिकली हमारे डेथ्स भी 65% पे रिड्यूस हो जाएंगे। तो ये उसकी एक टारगेट थी और हर नेशन को ये टारगेट दिया है, ये टारगेट आपने अचीव करना है। स्ट्रेटेजीज जो कि आज का टॉपिक है, हाउ द स्ट्रेटेजीज, व्हाट आर द स्ट्रेटेजीज, इसके लिए इस डायग्राम को समझने की जरूरत है। देखिए ये हेपेटाइटिस पूल है, आप इसको पूरी दुनिया का लें तो कोई 315 मिलियन लोग हैं, अगर पाकिस्तान का लें तो ये तकरीबन कोई 2 करोड़ बनते हैं। तो ये हेपेटाइटिस पूल है B और C। इसमें एंट्री कैसी होती है, जब इन मरीजों से, जो कि मरीज इनसे कोई नॉन इन्फेक्टेड बंदा इन्फेक्ट हो जाए तो वो भी इस पूल में आ जाएगा। एंट्री होती है, किसी भी टाइम पे उसकी एग्जिट भी होती है। इन पूल से लोग निकल रहे होते हैं, कैसे? या तो खुदा ना खास्ता उनकी डेथ हो जाती है, या जब इनका इलाज हो जाता है तो वो बाय क्योर इस पूल से निकल जाते हैं। तो अगर हमने इस पूल को, इस जो जितने भी हमारे पूल है, अगर इसको हमने कम करना है, इसको हमने श्रिंक करना है, कि जिस तरह कहा कि 8 मिलियन से अगर हर साल 80 लोगों का ये पूल रहता है, इसको अगर हमने 9 लाख पे नीचे ले जाना है तो हमने एंट्री भी बंद करनी है और हमने क्योर भी करना है। तो एंट्री बंद करेंगे तो मजीद लोग नहीं आएंगे इस पूल में, और जब एग्जिट हम ज्यादा से ज्यादा लोगों का इलाज करेंगे तो ये पूल सुकड़ता जाएगा। तो 2 स्ट्रेटेजीज हैं हेपेटाइटिस एलिमिनेशन के, एलिमिनेशन बाय प्रिवेंशन एंड एलिमिनेशन बाय क्योर। तो ये 2 कंपोनेंट्स हैं, 2 आर्म्स है, 2 हाथ है, और हमने दोनों हाथों पे काम करना है। वेल, तो WHO ने भी यही लिया कि एलिमिनेशन बाय क्योर एंड एलिमिनेशन बाय प्रिवेंशन। एलिमिनेशन बाय क्योर यही था कि अगर एक कॉन्सेप्ट है कि अगर 100% पेशेंट्स हैं जिनको, 100% अगर 100 लोग हैं जिनको इन्फेक्शन है, तो टेस्टिंग कम लोगों की होती है। जो टेस्टिंग होती है उनमें से बहुत कम लोगों को पता होता है कि मेरा PCR पॉजिटिव होता है कि नेगेटिव होता है, उससे भी कम लोगों का इलाज होता है और उससे भी कम लोगों का इलाज पूरा होता है। तो देखें, अगर ये 100 पेशेंट्स हैं तो ऑलमोस्ट अब होता क्या है कि लेस देन 20% और 20% लोगों का फुल इलाज होके उनका फॉलोअप होता है। तो हमने इस बार को ऊपर करने यहाँ तक पहुंचाना है, कोई 90% को हमने कवर करना है। तो ये कैसे होगा कि हम प्रॉपर टेस्टिंग करें, जब टेस्ट पे जो पॉजिटिव आते हैं उनको लिंकेज टू केयर, जहां उनका इलाज होता है उसके साथ उनको लिंक करें, उनको इलाज किया जाए और इलाज के बाद उनका फॉलोअप किया जाए कि आए ये मजीद या दोबारा तो इसको इन्फेक्शन नहीं हो रही है। साथ में साथ एक प्रिवेंशन का भी कंपोनेंट है जो कि चलेगा। वेल, तो प्रिवेंशन में कौन से कंपोनेंट्स हैं ये तो मैंने बता दी कि इसके 4 कंपोनेंट्स थे। बाय क्योर के टेस्टिंग करो, लिंकेज टू केयर करो, ट्रीटमेंट दो और क्रॉनिक केयर करो। इसी तरह प्रिवेंशन के भी 4 मेन कंपोनेंट्स हैं इस स्ट्रेटेजी के। कौन से हैं? ब्लड एंड इंजेक्शन सेफ्टी, कि किसी को भी ब्लड लगे वो स्क्रीन्ड हो, और अगर जो इंजेक्शन यूज करता है चाहे थेरेप्यूटिक है या वो जो ड्रग लोग हैं जो कि अपने आप को इंजेक्शन लगाते हैं, IV ड्रग यूजर्स हैं, वो साफ इंजेक्शन इस्तेमाल करें। दूसरी बात हार्म रिडक्शन, तीसरी बात 3 डोजेस ऑफ हेपेटाइटिस बी वैक्सीनेशन, और 4th जिन माओ को हेपेटाइटिस बी है जब उनकी ज़चगी होती है, जब उनकी वहां बच्चों की पैदाइश होती है, तो माँ से बच्चे को हेपेटाइटिस बी प्रिवेंट होने से बचाया जाए। तो ये 4 कंपोनेंट्स हैं स्ट्रेटेजीज ऑन द एलिमिनेशन बाय प्रिवेंशन टाइप। ये WHO ने बड़ा क्लियरली बताया है।
डॉक्टर
2015
Yes, sir. As few participants from Afghanistan, they are, unable to understand Urdu language, so they are requesting for, maximum presentation in English. That's the request from one of the doctor from Afghanistan.
Okay, sure.
Thank you, sir.
Let it be okay.
Thank you.
Thank you. Well, thank you. Thanks for guiding me. Well, so you see, the WHO Regarding this first component, that is the cure by the prevention, elimination by the cure. So for the testing services, what the WHO put the target that in 2015, only 9% of those of the total B patients, they were being tested. WHO said that by 2020, 30% should be tested. And by 2030, the 90% should be tested. To reach those targets, the 90% reduction in the incidence and 65% reduction in the mortality. Similarly, for HCV, in 2015, only 20% of the total patients present in that pool were tested. And WHO said that this should be increased to 30% by 2020 and 90% by 2030. So we should be investigating and diagnosing those patients who are not diagnosed nowadays, who are silent patients. Then on the treatment side, WHO, by in 2015, only 8% of the patients with, known case, they were treated. WHO said that in 2020, in the world, 5 million patients should be given treatment. And in 2030, it should be 80% of the total diagnosed cases. Okay. Similarly, for hepatitis C, in 2015, only 7% of the patients, they were getting treatment. And WHO said that in 2020, it should be 3 million, and in 2030, it should be 80%. So in 2030, the 90% of the B or C patients who are in the pool, they should be tested, and 80% of the positive or the tested patients, they should be getting treatment. What was the ratio? You see, this was the 9% in 2015 when the WHO was launching hepatitis elimination program, and here it was only at 7%. On the prevention side, about each arm, the WHO has also set targets. What? In blood safety, in 2015, it was reported by the many countries that they are doing the screening, and WHO said that it should be 100% by 2030. Injection safety or unsafe injections, in 2015, it was only 5%. The injections were not safe. WHO said all injections, they should be safe. Unsafe injections should not be used at all. Okay. And the same was for 2020, because this is the main source of transferring patient from infection from the patient to the normal people. Okay. Then harm reduction. Those people who are using injections, for them in 2015 per year, 27 injections were given free per patient. They said that if you find that this is a drug abuser or somebody is in the need of injection, per year 300 injections per patient should be provided. So this is again a target. Coming to the HBV vaccination, because this is a very effective. So in 2015, it was reported to the WHO. I doubt the figure is not that high, that 84% of the people, they are getting infection. I think in Pakistan at least, and in Afghanistan, it's not that way. But WHO said by 2020, 90% of the population should be vaccinated. I'm sure we are far, far back from this. We have not reached this target. And the same in 90% adult population in any country, and children should be vaccinated. I think this is a dream, at least for Pakistan and Afghanistan, that it's not that status. For hepatitis B, transmission from mother to child, in 2015, the 39% of the baby born, they were given injections in HBIC, and WHO said that in 2030, it should be 90%. And this side again, I think we are lagging behind in Pakistan as well as in Afghanistan, I'm sure. So what are the challenges in hepatitis elimination? I discussed with you that these are the strategies: elimination by the cure and elimination by the prevention. Elimination by cure means you test the patient, you link the patient to the treatment, give the treatment, and then the follow-up, 4 arms. And in the prevention was that you safe blood transfusion, safe injections, harm reduction, as well as the HPV vaccination and prevention of the transmission from the mother to the child during childbirth. So these are the two strategies. What are the challenges? Let's see. Challenges are on both arms. In elimination by prevention arm, as well as in elimination by the cure arm. On both sides, there are challenges. What are those challenges? In elimination by the prevention, challenges are safe injections. I think we have been unable to make sure that all injections given to the patient is safe and indisposable. So this is a great challenge, that how to ensure that everybody gets the safe disposable blood injection. So I think this is one of the big challenge. Then safe blood transfusions. Again, this is even by law that the blood should be screened, but how much it is executed in real world, I think I don't need to explain it. We all know it's a big challenge for us in the world, in Pakistan as well as in Afghanistan as well. Safe interventions, if surgery is done, dental procedure is done, gynecological procedure is done, some minor surgery is done, how much safe the instruments are, how much proper precautionary methods are being used. This is again a big challenge for us. Again, the safe sex, if one of the partner is B or C positive, especially B positive, because B is one route is the sexual route, the marital relationships and extramarital relationships. We all know this. So how we are practicing safe sex, this is another big challenge, and we should educate the spouses, the families, and even the sex workers that this is very important. So this is another challenge to us. And then the HPV vaccination. Many countries reported to the WHO that 84% coverage is there, 39% coverage for the B prevention from mother to child is there. I think in Pakistan, it's only in probably maybe in just 10-15%. I think it's not that. And in Afghanistan, I think it's a dream for them. My colleagues from Afghanistan will agree that probably it's a dream for them. Well, there are challenges in hepatitis elimination on by the cure side as well. These were the challenges: safe injections, safe blood transfusion, safe intervention, safe sexual procedure practices, and HPV vaccination. They were the challenges on the preventive models. Similarly, there are challenges on the side of by cure. What are those? Testing. Are testing available to each and every person? I think not. Are they reliable? Most of the times, lab errors. Then costly. And if somebody is positive, finds to be HBS or HCV positive, then PCR testing, it's again very expensive. And if a patient becomes, is PCR positive, is the healthcare system links that person to the treatment? Again, I think our healthcare system is not, fully 100% covering that, linking that. This is another challenge. Then the treatment. In Pakistan, most of the times, the government programs are there where they provide the free drugs. But can it cover all those patients? Many of our patients, or most of our patients, they purchase the drugs. So is it affordable? And whether the patient are adhering with the drugs, especially for hepatitis B, it's a lifelong treatment. Do the patients that take this drug lifelong? A very big question mark. So this is another challenge. And chronic care, surveillance, prevention, hepatitis B or C, if they become PCR negative or B is controlled, still they are at the risk of, if they were cirrhotic, to have the complications, especially the hepatoma. Are they regularly coming to us for this surveillance? I think it's a big question. And everybody knows we have got very poor surveillance follow-ups of these patients. They forget, they don't come. So these are the challenges on the elimination by cure side. So if I sum up, if I see in both models or in both sides, challenges in the patient, challenges on the healthcare provider side, and challenges in the structural. I'll just enumerate those. On the patient side, the barriers is that access to healthcare professionals, they haven't got the, 100% access to the healthcare professionals. This is one barrier or one challenge. Competing health priorities. Suppose in a family, there's the mother is hepatitis B, diabetic, hypertensive, some other disease. Maybe they are poor, so what they do, the budget is mainly on the drugs of that. So this is again health, and then the health priorities. Health in the poor countries like Afghanistan, like Pakistan, it's sorts of a luxury. In those people where they don't have the arrangement for the, 2 times the meals. So again, this is how much priority they are giving. Then poor hepatitis knowledge. Patients don't give that attention or significance to the hepatitis. The knowledge is not that good. Asymptomatic infection. When the patient is not having any problem, they don't test it. Fears about treatment. There are, especially when it was interferon era, and stigma and discrimination. They say if I am found to be having hepatitis B or C positive, the people will start hating me and they will say, oh, ye kya? So this is how to solve this? We need to do community education, engage community to promote testing, and create treatment literacy material in our clinics, in our hospitals. So this is the way how we can overcome these challenges on the patient side. What are the challenges on the healthcare provider sides? Limited knowledge. It's not necessary that every healthcare professional has got the same knowledge. So this is another point. Treatment misconception. So we need to train them. We need to simplify model of care, and we need to decentralize hepatitis care to the primary level. It should not be that if somebody is BRC positive, the patient has to travel miles, 100 kilometers to another city for the treatment. This should be available at a village level, at town level, at tehsil level, at district level, everywhere. Because the treatment isn't difficult, but they need proper training and proper teaching. On the structural side, the challenge is probably the health providers are not that sufficient who can treat. National guidelines should be there. Like in Afghanistan, I doubt that there are Afghanistan guidelines. I know, I've got so many friends in Afghanistan, the doctors, they are eager for learning. They are so good. They are so dedicated to their profession. But is any society, is any organization exist there? Is the government has the priority to make program for that? I have seen the hepatitis B is so common in Afghanistan because the patients comes there. I've got so many good friends in Afghanistan. So this is one of the problem on the structural, the system. Then unaffordable diagnostic tests, hepatitis medication, high price, very expensive price. Can anybody afford? The doctor know that the patient needs this drug, but the doctor cannot cannot prescribe. The reason it's very expensive and the patient cannot purchase. So this is another issue. And of course, the national and regional hepatitis programs should be there. How to overcome this? Strong political commitment is very, very important. Funding to start hepatitis program is very important, especially in Afghanistan. I think there should be program. Decrease cost of care. This is another way how we can overcome this challenge. Estimate disease burden. This is very important. Most of my hepatitis B patients, they are from Afghanistan, but I doubt that is there any national study conducted in Afghanistan for B and C. In Pakistan, the study was conducted a decade before. And now when there was no sorts of elimination program, when it's elimination program, we should have reconducted it, another study to see what should be the priorities. So, where are the most of the patients, which are the most prevalent cities? In 2007 and 8, they identified some districts. These are the districts in each and every province where the hepatitis B and C is more highly prevalent. But have we rechecked whether our program has led to decrease in the prevalence in those districts? I think not. We haven't conducted another or the follow-up national BC survey. So I think it should be done, and estimate disease burden and identify high-risk groups. These are the ways, if we can do it, so probably we can overcome these structural challenges in the hepatitis elimination. I believe that every citizen in any country, whether this is in Europe, America, South Africa, Africa, Asia, India, Pakistan, Afghanistan, everyone has the equal right to be tested, to be linked to care, to be treated, and to be followed up. How many stairs you need to put on, how many money you need to put in, how many support you need to give, this is the responsibility of the government and of the civil society to help the individual to reach the level where everyone is tested, everyone is linked to care, everyone is treated, and everyone is followed up properly. So until and unless the government and civil society and individual, they are on the same line, probably the hepatitis elimination will remain a dream for us, for anyone. So I hope that this message is reaches to those who really matters it, who are the policy makers, who really plans that this is really some sorts of that where it will eat our economy. It will it results in you see when in Pakistan in hepatitis C, most of the deaths there are in the people who are less than 50 years of age. And similarly, my patients coming from Afghanistan, they are very young breadwinners, but they have got very advanced disease and they die. Why it should be? The reason is that our system is not catering for all those. So thank you very much once again, Sami Pharmaceutical, for giving me this opportunity to share my thoughts with my audience. And now if there are any questions, I'll be more than happy to take those questions. I tried to cover up that time which we lost in the net connectivity, and I hope that we can answer a couple of the questions that is in our audience minds. Thank you very much.
Thank you very much, Professor Farooqi. There are a few questions. मैं सर इसमें से रीड करता हूँ. एक क्वेश्चन था सर, ये है डॉक्टर बिलाल अफजल. How can we manage and treat acute viral hepatitis?
You see, depending upon acute viral hepatitis, it may be because clinically, this is the acute hepatitis A, acute hepatitis B, acute hepatitis E. C almost never presents as acute hepatitis. It does, but very rarely. In the whole of my life, probably I've seen only 4 or 5 acute hepatitis C patients. So here, for A and E, they don't go into chronic phase. This is one point, okay? Second is that good point is that they are self-recovering, provided you support the liver and you help the liver. Only less than 1% of acute hepatitis E, they can develop fulminant hepatitis and die. Coming to acute hepatitis B, in adults, in more than 95% of the patients, they recover spontaneously within 6 months, provided they haven't gone to that acute liver failure stage. If they have gone to acute liver failure stage, PT, INR prolonged, and sorts of encephalopathy, all other parameters, it's not a time to discuss all those, then we may give to very selected patients the antivirals. But you see, the problem with antiviral is if you give them the tenofovir like that, it controls that acute flare, but the number of patients, acute hepatitis patients, if there are 100 acute hepatitis patients who were not given any antiviral, 95% of them they recover. But if there are 100 patients whom we gave the antivirals, only 70 or 80% they recover, rest they go into chronic phase. So they treat the acute flare, the liver, but at the cost of more patients going into chronic phase. So for acute hepatitis, the liver should be given rest and supportive treatment, all those things. Otherwise, there are nothing, any issue, but they should very closely monitor. And they recover, and they do recover.
Sir, another question from Dr. Miraj Muhammad. Which antiviral is better for hepatitis B management? Entecavir, tenofovir? And second question, इन्हीं की तरफ से, can we give the booster dose of HBV vaccine and when?
Okay. Coming to the first question, that tenofovir and entecavir both are the first line, first choice, rather the only choices. In tenofovir, we have this TDF and TAF, where the TDF is having in long term some sorts of the renal side effects on the renal as well as on the bones, while the TAF is safe in that. To start with, you can start anyone. The literature says that resistance is almost negligible with tenofovir even after the 7 years, and with entecavir around 1%. But still, that is questionable whether this was the really resistance or the patient were the poor adherent patients. Okay, so you depend upon what patient you are treating. Suppose if you are treating a pregnant lady with hepatitis B, then the option is tenofovir, TDF, even not the TAF. If you are treating just chronic hepatitis patients and normal liver, you can go for anyone. If it's elderly, 65 years plus, a patient with some osteoporosis, then you will go for the TAF or entecavir rather than TDF. If a patient is cirrhotic and some sorts of decompensated cirrhotics, if you want to give that patient treatment, then it will be TAF is not safe, and entecavir in double dose and TDF can be given. So it depends upon the patient, which patient you are treating. But there is, believe me, no edge of one over the other. They are all equal, and they are all very good drugs.
And sir, second part.
Yes, for the vaccination.
Yes.
Yeah. The booster used to be given by the initial one, which was the Engerex, that we used to give the booster dose after 3 to 5 years. But then the other genetic engineering vaccines came where there was no booster dose needed, and the antibodies were accessible. So the booster is not universal that each and every person should be getting the booster. But if it's a high risk or at the risk of acquiring infection by the job or something like that, then it's not a bad idea to give the booster after 3 to 5 years, or even you can give one at the 1 year and then after 3 or 5 years. So here its opinion is split, but when you complete the 3 doses, that's the reason in WHO it has not been recommended of any, and no mention of the booster dose. This is the 3 doses. When you receive the 3 doses, you are done. But in fact, when you have got already immunized, you got the antibodies, if you get the infection by chance prick, that works like a booster for you, because if you got the antibodies there.
Sir, another question from Dr. Shweb, DHQ Rajanpur. What will be the endpoint of treatment of hepatitis B?
Okay, that's a very, very important question. You see, with the current drugs available, you see here with all the tenofovir or the entecavir, even with interferon, we are unable to eradicate hepatitis B from the hepatocytes. It always lies there in the form of cccDNA. Okay, so with these 2 drugs, the ideal endpoint is HBs antigen seroconversion, or HBs antigen becomes negative. Okay, with this kind of treatment, if your patient is cirrhotic, you see, this is a very, thank you for asking this question. That was wonderful by Dr. Shweb. If your patient is cirrhosis or high fibrosis, and you find out the fibrosis simply Fib and April score. If your patient is cirrhosis, then your patient will need this either tenofovir or entecavir lifelong. Irrespective, the PCR becomes negative after 1 month. Still, the patient will need lifelong. Okay, so this is very simple. That in cirrhotic patients, lifelong this antiviral. Okay, entecavir or tenofovir. If your patient is having no cirrhosis, just a normal liver, then if patient is HBe antigen negative, When you check the patient, we divide hepatitis B into HBe antigen positive and negative. This is HBe antigen negative. Even with normal liver, again lifelong, because the target point is HBs antigen surface negativity, and it is achieved only 1.5 to 2.5% per year. It means if he is in the lucky enough in the first year, his PCR becomes negative, so okay. Otherwise, if he is in the last 1.5, he or she has to wait for 100 years. So it means it's lifelong. Okay, it becomes HBe antigen positive chronic hepatitis B and normal liver when the patient PCR becomes negative, E antigen becomes negative, and the patient receives at least 1 to 2 years treatment, and after that, both these negative, E antigen negative, PCR negative, for another 1 to 2 years you give this treatment, and then you can stop, but with close monitoring, whether this recurs or not. So practically, with these two drugs, what I tell my patients that, you see, if I start this treatment, you have to take it lifelong, just like hypertension, just like diabetes. It should be clear. It's only if out of 100 patients, probably in 5 or 10% of the patients, you will be able to stop it. Otherwise, you have to continue. That's the reason, please don't jump on antiviral, starting antivirals in each and every PCR positive patients unless it is really indicated. You see, this is very, very important point. So once you start, probably you cannot stop it, because the ultimate is the HBs antigen negativity, but still each patient is at the risk of complications. So hopefully new drugs will be introduced within 2 to 3 years, maybe within 4 years, next 5 years, at least we'll be having 1 or 2 drugs where you can give defined therapy for 6 months or 1 year or something, and then probably the cccDNA will be clear. So with this therapy, it's almost lifelong.
Sir, one more question from Ihsanullah Alakzoi. He want to ask from you that if the PCR still positive after the whole treatment, after 3 or 6 months treatment for the hepatitis C, then what would be our next plan to treat such patient?
He is asking hepatitis C.
Yes, sir.
Okay. So see, for hepatitis C, we are lucky enough that right from the interferon and what the current drugs are, we can eradicate, we can cure that patient. Why? In hepatitis B, the virus enters the nucleus and it stays there lifelong. In hepatitis C, the virus lies within the cytoplasm. So it's easy to clear the cytoplasm from that virion hepatitis C virus. So days are gone when we used to give them the interferon and ribavirin. Okay. Then came another drug that was the sofosbuvir and ribavirin, and we used to give this for 6 months. Then the declotesvir came, and again we used to give it for sofosbuvir, declotesvir with or without ribavirin for 3 to 6 months, depending upon the patient's status. Okay. Then after that, the velpatasvir came. So sofosbuvir, velpatasvir combination with or without ribavirin from 3 to 6 months, depending upon the liver status and all those things. If a patient has used sofosbuvir, ribavirin and no other drug, then you can try soft decla, but I'll say try soft and velpatasvir. But if a patient has used soft and velpatasvir, you say 3 months or 6 months, and patient was honest in taking drugs was good quality, this is again another point, then the other options are soft, velpatasvir and voxilaprevir. Or then the GP, or one is, and because only these 2 drugs, one is the Vosevi, one is the Meverit. But Vosevi, both are these drugs, they are very expensive, especially the Meverit is very, very expensive, probably out of range of our people. Vosevi can be, but this is not where it is only on patient demand and the patient has to import. So options are there. So if a patient, what I'll suggest, if a patient liver is okay, if a patient is not cirrhotic, and if condition is okay, better you wait till those two molecules are available by the local brands. Okay. But if the patient is really high risk and can go into, worsening of the disease, then you have got no option. You have to import that drug for that very patient.
One more question about the like supportive therapy, like the role of syrup, like LIV52 for the treatment of acute hepatitis or for the management of such acute presence. What is the exact role of these supportive therapies, like vitamin E or the syrup, like liver 52?
Yeah. Okay. Thank you very much. You see, these are the drugs which are mostly prescribed, are very in huge number. They are prescribed. They do, help in reduction of the liver enzymes. Okay, they do. Yes. Whether this is a placebo effect or this is a true effect, but they do. The milk of the cell so far the silimarine, which is, and there are a lot of claims behind that because of this mechanism, but all those mechanisms which have been, in the literature behind all those mechanisms, if you go through the studies, those are animal studies. Okay, in humans, yes, not end-to-end or proper studies are there where they've got an impact on the viremia. No impact, but yes, they are the liver supportive. They are helping the liver. They are multivitamins. They are something like that. So we do give, but what I'll suggest, if your patient is at the some sorts of decompensation, or the PT is very prolonged, or some sorts of very high enzymes, I will say please abstain from this. We don't know what will be these drug effects on the liver. There is a term called drug-induced liver injury, and any drug can cause. So if the liver is really very ill, I will say that avoid these. It should be liver rest, good nutrition. Okay, and to me, what I'll say, these are the salads and fruits for the patients, that the drug salads and drug fruits. Otherwise, I do also prescribe, but why? Because patient does not. If you don't prescribe, patient may use something which is really harmful. So it should be very something. These are the drugs just like a supportive. Not that these are the definitive treatment. There are no definitive treatment. Hepatitis B, 95% self-recovery. Hepatitis C rarely presents acute hepatitis. Hepatitis A and E, they're self-limiting. You just need to support the liver. Don't overburden. Don't do that all parhaiz and all dietary restrictions. Please, there are no dietary restriction recommended anywhere in any guidelines in acute hepatitis patients. It should be nutrition, frequent nutrition, high calorics, and to the taste of the patient. These patients, they like one dish at one time, and just after a few hours, they have some eager for something else. So don't, stop them. No ghee, no, there should be no oil, there should be no meat, there should be no, please, it's not that way. Okay, this really damages the liver. Okay.
Sir, we have a lot of questions, which is I think very difficult to cover in this short period of time. I think we can take the last two questions, and then a few participants, I think from Afghanistan, raising your hands. Maybe I can unmute one of them. So that's a good way of interaction. One question from Dr. Afzal: how often should we do surveillance for prevention of HCC in responders of hepatitis C or B, treated patients?
Yes. Very important question. You see, the surveillance, by surveillance we means that we preemptively try if there is any lesion happens, so we detect them in time. It depends upon the liver status and the time you start surveillance. If your patient has got normal liver, no cirrhosis, then to start with, you will, and the patient treated with DAAs, of course, nowadays we are treated with DAAs. You've done the ultrasound, prior to treatment or at the end of the treatment, better you repeat the first ultrasound after 3 months along with alpha-fetoprotein. And always it should be the same person and properly qualified trained person. Then you can have another ultrasound alpha-fetoprotein after. So the first two, they should be 3 monthly, and later on, if the liver is completely normal, you can extend this therapy from 6 months to even 1 year. Okay. But if the patient is cirrhosis, because the appearance of hepatoma, HCC, is directly proportional to the severity of the liver cirrhosis. And we classify liver cirrhosis into 3 main groups: child class A, child class B, child class C. Child class C is the most compensated at good liver, good cirrhotic liver. And child class C is the worst cirrhotic liver. Child class B is in between. So in child class A, chances are least among cirrhotics. The most least are in the normal liver. Then comes the risk is higher in child class A, then higher from child class A into child class B, and highest in child class C. So if your patient was in child class C or child class B, I will say for 1 year, first 1 year, 3 monthly ultrasound and alpha-fetoprotein should be done. And ideally, 3 monthly should be done for another 1 to 2 years. If that's not possible, at least 6 monthly ultrasound is mandatory for cirrhotic patients, especially if they are decompensated. Because until and unless we pick the hepatoma HCC in early stage, we cannot do that. But another point, we do surveillance if we are in a position that if we can get a small lesion at the curative stage, we can offer that patient treatment. This is another point. If suppose patient is not willing, or we say this patient will not will be able to go get the treatment because that treatment is very costly. So then we have to arrange something or link that patient to some system where if the HCC appears, the treatment is offered, as a gratis or as a help or something like that. So you need, see, when you are following a cirrhotic patient and post-treated patient B or C, you got a high responsibility to do the surveillance as well as ensure that if I get the tumor, I can offer the treatment, whether the patient can afford or I have some system which will help the patient for that, because every treatment in that case is at least 4, 5, 6 lakhs rupees. It's not cheaper.
Thank you very much, sir, for elaborative answer, sir. One more last question, most probably Dr. Naimatullah Sajid from Shahupura. He's asking about the metabolic syndrome. As a patient which already have a metabolic syndrome like diabetes, hypertension, how much, what are the chances of such patient to catch, hepatitis specifically? And maybe is there, different chance of getting infection from the healthy person? And number 2, what is the severity of the complication in such patients which already have a metabolic syndrome? If that patient can catch, if got another disease like hepatitis B or C?
Yeah, again, a very important question and a very relevant one to our clinical practice. But the first point, that a patient with metabolic syndrome is the patient is at the higher risk of getting HBV or HCV. Per metabolic syndrome, answer is no. But if a patient is metabolic syndrome and the patient is diabetic and patient has been prescribed injections insulin, getting every day 2 to 3 injections, so the injection safety things comes that, that will be one thing, that yes, daily injections may predispose that person to getting infection. Otherwise, metabolic syndrome does not predispose you to get infection. Only through this route it can. Okay. Coming to the impact of the metabolic syndrome on the course of the chronic hepatitis B and chronic hepatitis C. Yes, it's well known that the metabolic syndrome, diabetes, hypertension, especially the diabetes and the fatty liver, they have got a negative impact on the this hepatitis B and C in 2 ways. Untreated cases, they progress rapidly I mean, in the fibrosis progress rapidly as compared to those who are who are not having metabolic syndrome, untreated cases. The reason is that metabolic syndrome has the fatty liver, and fatty liver, you know, this is the start of the NASH. So now the metabolic liver, just like metabolic syndrome, we call that metabolic liver. So metabolic liver is not a normal liver, it's already stressed liver by the fatty acids, and even by itself, it is at the risk of developing fibrosis and cirrhosis. So if another infection comes, you know, it will be two enemies on one target. So this is one point. Second is, even if you treat them, the chances of getting PCR negativity or response, it's low in the metabolic liver. The reason, again, the same, that this is not a normal liver, its metabolism, its immune system, it's all are some sorts of compromise because of the fatty liver. Okay, so yes, these patients, they are at the high risk of getting infection unless daily injections, insulin or something like that. But they accelerates the natural progression of the disease, and they results in lowering of the, less response. And another point, B and C treated cases with metabolic syndrome, the chances of hepatoma will be higher in this group. Why? The reason is now the liver is a treated or recovered case from hepatitis B and C, plus it has got a fatty liver as well. So it's simple mathematical answer that yes, they are at the high risk.
Thank you very much, sir. I think just one, I need to unmute one person from Afghanistan. Dr. Khushir Ahmed, I'm going to unmute you. Please ask your question or any comment.
Dr. Khurshid Ahmed? I think he's not muted. He's still muted. What I see, he's, yeah, he needs to be unmute. Mohammed.
So I'm trying to unmute him.
Yeah. Yeah. You see, in today's
maybe some kind of issue.
You see, the today's Zoom is really offering me so many challenges.
So I think I can try someone else.
Yeah. I think it will be good if we can chat with our colleagues from Afghanistan. It will be very good.
Yeah, Dr. Muhammad Qasim Zurmati from Afghanistan.
Also, we are unable to, hear you properly. मेरा ख्याल है कि there's some distortion. Yes, please speak, please.
Yes, sir. The first question is for hepatitis B in pregnant women. For how much time we will advise tenofovir until term or after term? Also, we will advise tenofovir.
Yeah. Okay. Thank you very much. A very great question. In pregnant ladies, if you started the patient on tenofovir to lower down, to control the viremia and to prevent the transmission to the fetus, there are two ways. One is to stop the delivery. One is to give 3 months till 3 months postnatal. And I am in that school of thought where when I start, I give till 3 months postnatal. The reason is we will keep the viral load controlled till the 3 months seems to be more safe. The child is getting the feed, and child 3 injections are not completed yet. because the child will receive the first injections at the birth, then second injection after 1 month, and third injection after 3 months. So for what I say and what I do in my patients, I give them for at least 3 months postnatal, provided the mother was not a candidate for treatment by herself. Suppose it was just our aim was to prevent the transmission from the mother to the fetus. But if the mother qualified for the treatment, I mean, it is a possibility that mother viral load was high, ALT was high, liver was compromised. So, and we started the treatment, we found her just during the pregnancy, then in that case, we will continue the tenofovir. But if the aim was only and only the infant, in that case, I suggest and that we should give it for 3 months, at least 3 months postnatal. So to make sure that the child does not get infected, and by that time, child will be vaccinated by the 3 doses of vaccine.
Thank you very much, Professor Javed Iqbal Farooqi. I tried a couple of times to unmute Dr. Khurshid and Dr. Amir, but I was unable to unmute them. Thank you very much to all the participants and attendees for your time. Thank you on the behalf of Sami Pharmaceuticals to spare your time and to attend such a wonderful lecture from Professor Javed Iqbal Farooqi, which is always a very deft in and have a deep command on the disease part as well as the management part. Thank you very much, Dr. Javed Iqbal Farooqi, for sparing time for the Sami Pharmaceuticals Private Limited. From this, we are going to close this live webinar. Thank you very much, and Allah Hafiz.
I'm thankful especially to you and the whole of your Sami team. I really enjoyed, and it's really always been a very good experience to be, with you. So inshallah, Aziz, we continue these efforts. Allah isko kabul kare. Thank you very much.
Inshallah,
God bless you.
Thank you very much, sir. Allah Hafiz, sir. Thank you very much.
Thank you. Thank you.